Okay, as we're getting set up, again, my name is Lori Guelman, and I'm a lead advanced practice provider in the Urology Oncology Clinic, and I'm also the lead for the Radiation Oncology Clinic. Today, my talk is going to be on prostate cancer screening and active surveillance. Just a reminder, if you do have questions, we have a live stream, so we need to make sure that they hear, so please write it down. Our runners will pick it up, and just so we can make sure we get it in the microphone. Okay, and with that, let's go ahead and get started. Okay, so why are we here today? Prostate cancer is the most common type of cancer in men, as you can see from the slide, 27%. And basically, this comes out to 6% of all cancer deaths in the US. 1 out of every 8 men in their lifetime will have prostate cancer. And if you break that down for African American or Black men, it goes to 1 in every 6. And the question is, why do African American or Black men have more incidence? And while we don't really know the answer to that, it certainly can be related to racial bias as far as preventative care, getting screened early and on time. So this is an area we need to continue to work on. You can see from the slide here as well that the increased incidence in that community. Now, on the right, it shows the fact that 5-year relative survival over the past couple of decades has really improved. And what this means is, if we are able to find prostate cancer localized to the prostate, survival rate is essentially almost 100%, which is really reassuring. Once the prostate cancer goes outside the prostate, then that number does decrease. So our goal is really to find those prostate cancers that are high and aggressive early while they're localized, so we have better outcomes. Okay, so what are the major risk factors? We break this down into what we call non-modifiable risk factors, which are those that we cannot change, and those risk factors that we can change. And as you can see, age certainly plays a role. The older we get, we do expect men to have prostate cancer, median age being 66. Race, which I just spoke to, African American, Black community has more incidence than the white community or other populations. Genetics certainly plays a role, the BRCA genes. Family history, we very much are aware of that. And then the modifiable risk factors being weight, diet, and smoking. So these 3 areas we really want to stress are where you can focus on really trying to improve. Exercise, going out for those walks, eating well. You know, although the research is not very strong, we do really encourage the Mediterranean diet, which includes fruits, vegetables, fish, and really moderating how much red meat you have and alcohol, and of course smoking. So let's get to the basics, the nitty-gritty. So what is the prostate? The prostate basically sits in between the bladder and the rectum. As you can see here, it's the shape is more like the size of a walnut. And basically the main job of the prostate is to produce seminal fluid that protects and transports sperm out of the body. If we were to go ahead and open up the prostate, this is what you would see on the inside. And basically the point of this slide is to show you that that purple area is what we call the peripheral zone. And this makes up about 70% of the prostate, and this is where we see most of the prostate cancers. And so when people do digital rectal exams, this is the area they're getting. In a rectal exam, you're not getting anything but that outside peripheral area. And so, like I said, the majority are on the outside. That yellow area is known as the transition zone. And we do, in fact, see a good amount of cancer in here as well, but to a much lesser degree than that outside peripheral zone. And then the other area, the green area, is called the central zone. And we do tend to see a little bit of cancer there, but not as much. So, what's the history of prostate cancer? As most of you probably know, it is very slow growing for the most part. And if not screened for a PSA test, obviously most men will not be diagnosed with prostate cancer and will most likely die of other causes, such as cardiovascular disease or other conditions. Most men who choose not to be screened, most men who choose not to be screened, like I said, will not be diagnosed. And although some of these people that who will not be screened will have prostate cancer, the lifetime risk of death is less than 3%. So, what do the guidelines say? The American Urological Association recent guidelines, as far as early detection of prostate cancer, tell us a whole bunch of things, and I'm really going to summarize it for you to take home some of these messages. Number one, shared decision making. What is shared decision making? That's basically the discussion between you, the patient, and the clinician. It's where you learn more than just the fact that we're going to go ahead and give you a PSA test. You get to learn and understand the benefits and the risks involved with that. Additionally, PSA is the first screening test. So that's going to kick off the whole process to see if you do have prostate cancer. If that PSA test is high, then rather than going ahead and getting an MRI or going ahead and getting a biopsy, the next thing to do would be to recheck that PSA, because as I'll discuss in a little bit, PSA is not a perfect test. And then once we get that baseline, then we want to continue to monitor it over time. And the guidelines have changed over the years. And it used to say 50, and then it said 40, and all over the place. And the most recent guidelines say that you should get a baseline around the age of 45 to 50. If you have a higher risk, meaning those non-modifiable risk factors, then you might want to consider getting your PSA at 40. And then based on your baseline, if it's pretty small, you can get it every couple of years. There's no need to get it annually unless there's an actual need. This is just another way to visualize going through the algorithm where it says shared decision making, which is extremely important, and I'll go over that in a little bit more. As you can see, DRE is on here. Don't have a pointer. So DRE is on here, but it's not as important in the process at this point. We have the MRI, which is a really good test to help us determine. So if needed, you can certainly do a DRE, but it is not as important as it used to be in the past. All right, PSA. So what is PSA? First thing to know is that PSA is a blood test, and it measures the amount of prostate-specific antigen in your blood. What I tell patients, and this is really important, if you can take one message out of my presentation today, it's this. PSA is not specific to prostate cancer. PSA is specific to the prostate. What that means is if you have an infection, if you have inflammation or irritation, if you've gone on a 100-mile bike ride, any of these things can increase that PSA value. And so one PSA in itself is really not a lot of great information. We have to do a lot more than look at that one value. The other thing to note is that we don't do PSA well. And what do I mean by that? I mean that we tend to give PSA or order PSA a lot for men who may not need it. Those are men who have, they're not going to live more than 10 years. They have a lot of comorbidities. They're older than 70 with all those risk factors. And we tend to not screen men who are younger with the risk factors where we might be missing a more aggressive cancer. And so what I want to really explain is that the goal of screening is to find not prostate cancer, but to find cancer that is high risk for spreading if not treated, and to find that high-risk cancer early before it does spread. And I'm going to say that a few times, and you might hear that throughout the day as well. So this is why it's really important that we do shared decision-making, having that discussion with your clinician, because we need to understand where you're coming from. There are many decision aids and online, and there's questionnaires for you as the patient to understand, is this a test I need? I'm 75, I have pancreatic cancer. Do I really need to get a PSA screening? And so you can see what your priorities are. This is a discussion to really review those benefits and those risks. So what are the risks, or what are the benefits, and what are the risks? The benefits, of course, of screening for prostate cancer is that you will increase the detection rate of prostate cancer. This does not distinguish whether it's low-grade prostate cancer or high-grade prostate cancer. It's just prostate cancer. So the other benefit is, yes, finding high-risk prostate cancer is what we really want to do before it spreads. Okay? And there's a randomized control trial suggesting that screening has at most a small benefit in reducing prostate cancer-specific mortality. So those are the benefits. What are the risks? Well, unfortunately, there's a lot of risks. You might say, yeah, it's just a blood test, but it's a blood test that kicks off the process. So you really need to understand each step in that process. First of all, knowing PSA and knowing that we know it's not specific to prostate cancer, there certainly can be a lot of false positive PSAs. That's why we don't look at PSA, we look at the trend. We look at numbers over time, and then that would give us a much better picture. Now let's say somebody actually has elevated PSA and we want to do a further workup. Then the next step would be a prostate MRI. Now, certainly, again, it's just imaging, no harm there, but yet people do have claustrophobia. There are the anxiety of having the procedure, of having waiting for the outcomes. And then once you have the MRI, if it's abnormal, then you just set yourself up for a biopsy. And as most of us know, the biopsy is not a fun process. And the biopsy itself certainly is invasive, and it can have a lot of side effects, and it can have a lot of risks, and there's a lot of anxiety around that. Finally, one of the risks or harms are overdiagnosis of prostate cancer. Again, prostate cancer itself is a very general term. We are looking for the prostate cancer that is more high grade and aggressive and concerning. And so a lot of men are diagnosed with prostate cancer, and it's important to understand that the low grade is treated very different from high grade. So what do the guidelines say? And again, I kind of touched on this, starting treatment 45 to 50, and if you're higher risk, 40 to 45. And what is really the numbers we're looking at? So the numbers we're looking at for a PSA cutoff are 4. And that's simply because the positive predictive value of cancer, if it's above 4, is 30%, meaning, yeah, there's a 30% chance that you can have prostate cancer. And if the number's less than 4, then there's negative predictive value, meaning 85% of men most likely will not have prostate cancer. Below shows that as you get older, that PSA gets larger, and we expect that because as you get older, your prostate gets larger, and therefore it makes sense that the PSA might get larger as well. So when we look at the PSA, we're not just looking at a number, we're looking at a bunch of factors that come with it. Your age, your prostate size, and your trends. All those are very important factors when we're looking at how to assess your PSA. So let's say you bought yourself an MRI. What exactly does that mean, and what are all these scores that are being thrown at us? So the MRI has what we call a PI-RAD score, and that PI-RAD score goes from 1 to 5. And basically, 1 and 2, and what we're looking for is clinically significant cancer. And so PI-RADs 1 and 2, there is a 7% risk of clinically significant cancer. And so for the most part, we tend to ignore this. Okay? When it comes to PI-RADs 3, that number goes up slightly at 11%, and this is more of a gray area, whether we need to do a biopsy or not. And so really it's where you look at the imaging to see if there's something concerning versus maybe just holding off and repeating that PSA in another 6 months. When it's PI-RADs 4 and 5, the numbers do go up for a likelihood of clinically significant cancer. And so if you see that your MRI, the lesion is a PI-RADs 4 or a PI-RADs 5, then you bought yourself a prostate biopsy. Let's talk prostate biopsies. So I'm just going to touch base, and I think one of our patient panelists might discuss this a little more as well. There are 2 types of prostate biopsies. There is the TRUS, the transrectal ultrasound biopsy. This is the standard and has been around for many, many years. This is where you lie on your side, you put a probe in the rectum, and then you go ahead and pierce through the rectum to get the tissue samples. Of late, we now have something called a transperineal biopsy, and what this is, instead of piercing through the rectum, you put the probe in the rectum, but now you pierce through the perineum. And so the way I explain this to my patients is that you go ahead and you put your feet up in stirrups like you're having a baby, so I can get a little laugh and make them a little relaxed. And then you go ahead and you elevate the scrotum, and then you put 2 tiny holes on either side of the scrotum, of course, where you numb it up, and then you go ahead and you get the targeted samples, okay? There are risks with biopsies. One of the benefits with the transperineal is that now you're not piercing the rectum, and you're able to get other areas of the prostate that you're not necessarily able to get with the transrectal. It takes about a week to get the results. You get about 14 to 18 samples, and when you get the samples, when you get the samples, you want to get the samples of really that peripheral zone area because, like I said, that's where you tend to see most of the prostate lesions. Side effects or things to be expected with a prostate biopsy are blood in the urine, blood in the rectum, and there is always a risk of infection. All right, so now you have done the biopsy, and what's different from the MRI, instead of having what's called a PIRAD score, now you have something called the Gleason score. And the Gleason score is rated from 1 to 6, and we're really more concerned about 3 to 6. And the way it's broken down depends on what the pathologist sees under the microscope. So if it's 1 to 3, you see this top up here where they're very discrete cells, and this is nothing to be concerned with, or a lot less concerning. When you get to 4, it's this middle area, which there's a little more condensed sheets, and number 5 below, it's really just this massive sheet of cells. You can't even see anything indistinct. And so Gleason 3 plus 3 is really the lowest grade we're looking at, and Gleason 5 plus 5 is the highest grade, and that's how we decide how to treat based on that scale. So I want to take a quick sample of Bob. Bob is a 71-year-old healthy male. He has a PSA of 19.5, a volume of 160 milliliters. That's a pretty large prostate, right? Somebody his age maybe should have 60, 70 cc's, but he's got a super large volume prostate. We have something called PSA density, which is basically the ratio of the volume to PSA. And this is important because we know that the larger the prostate, that might increase that PSA value. And so generally, if it's less than 0.15, it's a little less concerning than if it's more than 0.15. So all these are just factors that we take a look at. His MRI shows a 1.4 centimeter lesion in the transition zone, and this is a PIRADS 3. So as I mentioned before, PIRADS 3 is that gray area where it could be, it could not be something. And here's what an MRI looks like, and you'll see there's two pictures. The one on the right, oh, I'm so sorry, I wish I had a pointer. You can see the area with the circle, so that's the area in question. Over here, you can see there's a very bright area, and that's the same area that's dark onto the right imaging. And the right imaging is called T2, and this is a diffusion weighted, and basically I use it to really get that, that image more clear. And so then you do the biopsy, and in Bob's case, the biopsy came back being Gleason 3 plus 3. So this is really great news. This is the lowest grade cancer you can possibly have, 5% of the tissue. It's a very small volume of tissue. And this is known as a grade group 1. All the other core samples were what we call benign tissue. So this is a best case scenario for a pathology result. And that is going to help us determine the treatment, which I'll briefly discuss in a few minutes. Basically, all this information is now put in this what we call a risk stratification, and this is assigning risk levels to patients. And this is based on certain factors, which now all this information we have, we can put into this risk stratification, looking at the MRI score, the DRE, the PSA level, the Gleason score, and then that's going to help us decide, is it low risk, is it intermediate risk, or is it high risk? And that's where, if it's Gleason 3 plus 3, we consider it low risk. 3 plus 4, we consider it intermediate, but favorable intermediate. Gleason 4 plus 3 is unfavorable intermediate. And then 4 plus 4, 5 plus 5 are high risk. And all these factors, again, are going to help us decide treatment. Sometimes it's not quite clear what we need to do. It could be low risk on the verge of intermediate. Do we want treatment? Do we want to do active surveillance? And when we have these questions, this is where the biomarkers or additional germline testing, thank you so much, might be helpful. And so these are things that give us additional supplemental information. These biomarkers are becoming more a part of our workups. And basically, it's there are biomarkers that are blood or urine, or you can even get it from a prostate biopsy. And the goal there is to tell us, is this more concerning for a more aggressive cancer? And that's really what we're looking at. And this is just the NCCN has another way of doing risk classification. So this is one of my favorite slides, and basically this is what I explain to my patients when talking about treatment. How do we know what treatment to do? And really, it's a spectrum, and it's a spectrum based on, is the cancer low grade and not very concerning or indolent, or is it high grade, more aggressive, and we really need to jump on it? And based on this spectrum, that's where we're going to decide and work together on which treatment is most appropriate for you. The indolent or lower cancers, those are the ones that we want to put patients into active surveillance. And so basically the spectrum really can be active surveillance, and the farthest would be more whole gland treatment, things like prostatectomy and radiation. And in that middle is this area that Dr. San is going to talk about called focal therapy. All right, so now I'm going to throw another term at you, watchful waiting. And what is watchful waiting? So watchful waiting is not the same thing as active surveillance, and so I want to go over these few points. The difference between the two of these is that watchful waiting, there is no plan for definitive treatment. And so what does that mean? It means that we are just watching the PSA and we don't plan on doing anything, compared to active surveillance, which is really active serial monitoring. So we are actively watching that PSA to determine at what point you need treatment. 10 minutes, thank you. And what's the ideal population? So the ideal population for somebody in watchful waiting is somebody who's unlikely to benefit from definitive therapy, whereas active surveillance are patients who want to defer therapy for low-risk disease, which actually may never become clinically significant. So how do we know when to put somebody from active surveillance into treatment? And that's that whole process of watching the PSA, seeing the trend. If the trend becomes concerning, then we would move on to an MRI and possible biopsy to determine if that low-grade cancer is no longer low-grade. The goal of active surveillance is to avoid treatment in men where the cancer is really not likely to progress. And I tell patients, with every treatment except active surveillance, there are side effects. There are no side effects with active surveillance. And the whole goal is to avoid the side effects and maintain quality of life. And so, active surveillance is for very low risk cancer patients where we don't really anticipate any metastases, very slow progression, and that you're going to live longer than 10 years. And there was a trial done that actually separated people into, or men into, active surveillance, radical prostatectomy, and radiation. And basically what this showed is that the active surveillance does have a relative risk of clinical progression and would need treatment by 10 years. 50% of men might need treatment by 10 years, which means 50% of men may actually not need treatment at 10 years. And we've certainly worked with a lot of men who are in active surveillance 5 years, 10 years, even longer. At Stanford, this is what we tend to tell patients for men with low-grade prostate cancer, which is based on the Gleason score, the PSA, the stage. Active surveillance is the preferable management option. And about 40% of men will undergo some type of therapy within 5 years. Again, it could be 3 years, it could be 5 years, it could be 10 years. And it is a great option even for men who have 3+4, where that 4 is a very small volume. And so what this means is PSA checks every 6 months. If the PSA is concerning, we'd get an MRI, and if that MRI is concerning, then we'd do a biopsy to see if that Gleason 3+3 now went to a 3+4, and maybe now treatment is more appropriate. This is a recent study from the Journal of American Medical Association, which actually looked at the trends of active surveillance to see how well we're doing in the United States with our patients. It looked at over 20,000 men through electronic health records, and I'm happy to say that the rates of active surveillance in the past 7 years have gone from a measly 27% to almost 60%. That means that 10 years ago, if you had a Gleason 3+3, you probably had a prostatectomy or radiation. Whereas nowadays, if you have a Gleason 3+3, we're going to put you in active surveillance, and you're going to have your quality of life until we absolutely need to go ahead and start treatment. So, 3 take-home messages. Number 1, shared decision-making. Education and communication with your clinician and the team is very important to make a decision on prostate cancer screening. The goal is to avoid over-screening and over-treatment of that indolent, slow-growing cancer that is not going to go anywhere. And active surveillance for the right patient can really give you the quality of life without increasing any risk of mortality. Thank you.
Okay, thank you so much, Lori. That was great. We have a mixture of some online and in-person questions. So I guess one thing to kind of, if you can expand on a little more, is the notion that advises men to stop screening once they reach 70. Kind of a little more about that. Yeah, there's just a lot of
Okay.
confusion in the
Yes.
community.
So here's the thing with prostate cancer. It is not black and white. It's not just a number. PSA this just bought you this. Unfortunately, it doesn't work like that. So it's the same thing with age. If you're 70 and you're running marathons, then yeah, you probably have a lot longer to live, and we don't want to stop PSAs. So really, it depends on how well you're doing. If you have a lot of comorbidities, then yeah, maybe stopping at age 70. But if you're planning on living another 10, 20 plus years, then I think it's still appropriate to do PSA. Although that being said, we know that men are going to have prostate cancer. And again, the chances are they're going to probably die of other conditions. Dr. San, I see you in the audience. Do you have any additions to that? Sorry to throw you on the spot.
Do you want me to bring you a mic?
Yeah, I agree. I think it's important to draw the distinction between starting new screening and continuing with old screening. So if someone's 78 years old, is that the time to get their very first PSA? Probably not. But if someone's been continuing, has an abnormal PSA that you're monitoring, that you already know is high, that's a different situation than starting initially. In terms of stopping, it's really difficult. I'm on the panel through the NCC and the National Comprehensive Cancer Network, and we just had a meeting this last week, and there's a lot of debate, even amongst prostate cancer experts, about what should we say, how do we decide when the time to stop screening, because on a population level, it doesn't make a lot of sense. But then there's individual anecdotes of us as physicians who will have a patient or two that really stick out in our mind that benefited from screening. And so you get arguments between clinicians who know individual patients and the more population level epidemiologists who say to stop. So not an easy question to know when to stop screening.
Yeah, so I think the confusion is there for a reason.
Well, thank you both for the impromptu answer, Dr. San. Okay, so there's a question about Propecia for hair loss and how that can significantly lower PSA levels in men. Is this really giving men a false sense of security?
So I think Propecia is it 2 grams? I think so. It's finasteride. Finasteride is 5 milligrams, and what that does is if your PSA is 4, it's going to shrink it down to a 2 because what it does is it shrinks the prostate. So I think Propecia is it 1 milligram or 2 milligrams? I think it's pretty insignificant as far as changing PSA. So I don't think it's really something to be concerned with.
Thank you. There's a couple more. Does risk stratification use full probability distributions for decision analysis?
That's a good question.
Just to quickly go back to the Propecia one, it is a smaller dose, but it does still have the same impact on PSA value. So it will suppress the PSA level. You just have to take that into account when interpreting a PSA value of someone who's taking Propecia versus someone who is not. So it doesn't... It's not a reason not to take Propecia, but just have to think about the PSA value a little bit differently. I didn't catch the last question, though, that you said.
Does risk stratification use full probability distributions for decision analysis?
I can elaborate on that. Okay, that might be helpful.
Sorry, that's my question, and I am a mathematician. So you basically, the layman's version is you can drown walking through a lake with an average depth of half a foot. And if we use individual statistics, just numbers, as opposed to probability distributions that more fully characterize the population of people who may or may not need help, we might see a more nuanced understanding of who needs treatment and who doesn't. So the question is, when we look at these statistics for guidelines as clinicians, maybe we just have to look at a single number and say, yes, it's this or that. But if you're the individual patient, if you're the transaction, you want to have as much information about your probability distribution for the presence of different treatments for decision analysis as you can. And so the question is that kind of characterization available for patients? I'll take my answer while standing on one foot.
I mean, this, I think, gets towards the point we were just talking about, the difference between an individual and a population. And so, most of the research studies are going to look at a population level, and then it's left up to the individual and then the physician to try to make a decision based on that. Because ultimately, an individual, you're either going to die or you're not, and you can give you a 30% chance of something happening to you.
Can you speak
so
to that
the
in the
question
microphone?
was about
Yeah, thank you.
the Decipher score or other genomic test, and whether that helps more providing personalized risk assessments. I mean, I think yes, they do try to provide additional information that's based on that individual. At the same time, the way those tests were validated is validated on thousands and thousands of patients. So you're still left with imperfect information, yet you have to make a black and white decision one way or the other.
Thank you. So I think for the purpose of time, we're going to go ahead and move towards our next presentation, who is Dr. Jeffrey Son. He is a board-certified urologist specializing in prostate, kidney cancer, and I'm just so thrilled to introduce him. He's my colleague and partner in crime. So Dr. Son.